Добро утро, добре дојдовте. Ние македонците многу сакаме да критикуваме, а особено кога станува збор за критиките, тие се насочени кон здравствениот систем. Дека не е се така црно, односно кои се последните достигнувања кога станува збор за здравствените системи во светот. Денеска во ние имаме можност да разговараме со доктор Пракеш Јајакумар, хирург, научник и универзитетски професор од Dell Medical School при Универзитетот во Тексас, Соединетите Американски држави. Тој е еден од водечките експерти кога станува збор за така наречениот value-based healthcare, модел на здравствена нега кој го става пациентот во центарот и ја мери вистинската вредност на грижата преку резултатите, а не преку бројот на извршени процедури. Со него зборуваме за тоа како се менува модерната хирургија, што значи терминот вредност во здравството и какви модели би можеле да се применат и во системи со ограничени ресурси, каков што е нашиот македонски. Доктор Јајакумар, thank you for this interview with Telma.
Thank you.
To start, could you briefly tell us how your professional journey developed from surgery to research on health outcomes and value-based care?
Yeah, thank you very much for this opportunity. Yeah, I recall working in orthopedic surgery and recognizing the biggest step change for me, where it was going to come, was likely around health outcomes and changing outcomes of patients and data. And rather than necessarily innovations around implants or robotics and things like that, which are obviously great innovations, but I think for me, the care transformational kind of change and the value of data to drive decision support was the thing that kind of drove me very, very early on.
Even more than the robotics and...
Even more so, because I say, well, even if you build great robots, then how do you measure the impact of those? How do you create even better robots, and how do you create even better innovations? And so going at the heart of it, I believed that outcomes, and specifically health outcomes, reported by patients, generated by patients, both actively and passively, were probably the future. And so that was my hunch, really, during my training. And so, like all people who get passionate about something, you try and go to the best place to learn about these. And so I managed to get a scholarship at Harvard School of Public Health, managed to go and study health outcome measurement from the godfathers of this arena, John Ware and others who are really involved in like big social health experiments using health-related outcome measures, and started getting more and more passionate about that. And that for me was the kind of step change in recognizing the importance and power of these data and how they could influence decision making at both the individual patient level on the front lines of care, but also at a systems level, and creating healthcare transformation by looking at a population and looking at their outcomes and breaking down those outcomes by care delivery kind of phenotypes of care. And so that for me was like the kind of door into the arena of value-based healthcare, because of course value-based healthcare is the numerator is obviously the health outcomes that benefit patients relative to the cost. So no measurement and you don't then have a compass for driving healthcare transformation.
Your biography mentioned that you have worked in different countries, United Kingdom, United States of America, Europe, and focus on healthcare innovations. Was there a particular moment or experience that was a kind of turning point which motivated you to focus specifically on outcomes and value on healthcare?
Yeah, so during my training, I recognized the passion and the importance of patient-generated health data. Actually, when I was doing some research on spinal patients, adolescent patients with spinal curves, and we had an amazing population of patients to study. And I recall at the time, going through their scans and all of their clinical data, but having a complete like black box really around their perspectives around physical function, body perception, mental health, social factors, things like that. And so at that time, a new patient-reported outcome measure, or a relatively new outcome measure, came out in spinal surgery. And I thought, well, let's just use these. And we interviewed many patients on these outcomes. And ultimately, it's the story is one of moving from zero to, zero to heroes, I suppose. Again, it was an initial experience of failure because when we submitted it to the journal was like, well, you don't have enough clinical data here, and they didn't really grasp the what we felt was the unique selling point of the paper around patient voice. Jump ahead several years. The world of patient-reported outcome measurement research has exploded. And so for me, I think back to those early days and think, right, that was how tough it was to do health services research using these data. And now we're talking about evolving from patient-reported outcomes in the kind of research arena to the clinical arena and to implementing it at the point of care, which I think is a huge, for me, a step change. And so I've lived through that in my years, I suppose, in the arena. So as a clinician, I first, and then I became, I suppose, I built an academic portfolio. I studied patient-reported outcomes for my PhD at Oxford, looking at how you can use patient-generated health data to predict future outcomes after arm fractures. And so that, again, underscored the importance of these data. And then moving from academia to policy and practice innovation, I had a fellowship called the Harkness Fellowship in Healthcare Transformation, and that took me to the United States, where I was able to apply a lot of that knowledge, or build knowledge, but also apply that knowledge at the point of care to drive care delivery transformation. And now this is where I am.
How long is your professional background?
I qualified in 2002-3, and so there was a long...
So more than 20 years.
Yeah, that's right, yeah. So long road into surgical training, and then the academic training, clearly with a PhD and subsequent other degrees related to artificial intelligence, data analytics, innovation through various kind of opportunities, both in both sides of the pond. And through that, I'm now a director at value-based healthcare and outcome measurement.
And having on mind your huge experience and in different fields and living in different places, working in different places, could you tell us, comparing the health system, which one is the best? Which one should be the role model for the Macedonian health system?
Yeah, that's a really good and tough question to answer. I think that there are innovations and opportunities in many places that I've worked. I think from the UK, obviously born and into the health system and working through a universal healthcare system that is kind of heavily impacted by resource and challenges financially. You start thinking kind of with a frugal innovation mindset and thinking, right, what can I do to shift the needle towards better value care? And you think about pathways, utilization, high value behaviors. And I think that for me is a starting point. It's the bridge to value-based healthcare, where you think about coordination, cohesive care, streamlining care delivery, and not necessarily with more money thrown at it, but with resources that you have. And I think that's where those are really valuable learnings from somewhere like the UK. When you go to the United States, of course, there's sparks of innovation flying in many places. It's a large country with lots of amazing innovations going on especially in academic health systems and so on. But I think because of the complex environment, you start learning how to navigate as a systems thinker and think, how can I think about a system and multiple stakeholders and matching this idea of generating health benefits for the patient relative to cost and bringing both together. Often we talk about value-based healthcare, and every time I speak about value-based healthcare in the UK versus the United States, you get different receptions. Clearly, in the United States, there is now an arc of smart outcomes-based contracting and payment, and a movement towards linking outcomes and meaningful outcomes to payment, which is a huge step change. And so I think there are innovations going on at the systems and policy level, as well as the front lines of care. When you come to the UK, you mentioned, say, well, we're a universal health system. How do we, we already kind of have a high value system, right? For all the challenges that they face, and which is true. But I think that you learn very quickly that in the UK, they're looking at things at a population health level, and value at that layer is something you can learn tons around, because I think that's probably where the US can learn from the UK a lot.
You spoke about UK and USA. What about Europe? And please have in mind that I need an answer on this question in perspective of the patient view.
Yeah, of course.
Which health system is the best?
I'm going to be, what do you say, a little bit political about that. I think the best, it really comes down to what your metrics of success are, right? I mean, is it the best from the perspective of patient-reported outcomes? And I think, well, from the patient-reported outcome perspective, I think it really comes down to who's measuring, I suppose, these outcomes.
The perspective to approach of the health care.
Yeah, and I think that's where, if you compare, Europe, there's a lot of different types of health systems. Compared to the UK, the universal health system, compared to the US, an insurance-based, multi-layered insurance system. And so I think from the patient's perspective, it really comes down to who's brave enough to deliver the patient-centric care. So again, all the functions and services benefiting the patients relative to the cost. And so you'd have to say that the US is an outlier from a population health perspective amongst all the other high and middle income countries out there, of which, of course, Europe and UK sit there. And I think all the data and the research shows that there's a lot of work to do in terms of access, inequality, equity, waste, resources, and things like that. Many would argue that the UK is a highly efficient kind of system, right? And so technically, from a population health perspective, I think that there's definitely benefits to kind of more of that universal approach and healthcare for all approach. But still, I think you still need to link that up to a patient-centric approach to care. And so you probably end up looking further afield. The Dutch are really masters in moving forward with using patient-generated health data at the point of care, visualizing that data, having value-based systems set up with integrated practices. The UK as well has community integrated practice. They're delivering proms at a national level. I think there's sparks of these types of innovations going on that you can learn from around the world.
Maybe you have already explained or touched some topic of the following question, but lately the term value-based healthcare is used increasingly. Yeah. How do you define this concept? What is the definition? Yeah. And how does it differ from the traditional fee-for-service model?
Yeah, it's a great question. So value-based healthcare is care that is ultimately centered around the patient. And so the concept is borne out with the equation of health outcomes that benefit the patients relative to the cost of delivering those outcomes. So essentially every dollar spent accounted for in delivering those better health outcomes. And lots of discussions around whether, in the numerator of that equation is it really quality? Is it kind of process level efficiencies and clinical outcomes and things? But really it's patient, in its truest, kind of purest sense, it is health-related outcomes that benefit patients. Now, that could be discussed and debated. And of course, quality is part of that, experience is part of that, better process level outcomes is part of that. But really at the heart of it, it is whatever clinical condition area you're talking about over the full cycle of care, in that context, is it outcomes that benefit the patient? So for palliative kind of conditions, is it improving their capability, their quality of life, their mental and social health? Is it disease modifying? Is that kind of symptom intensity improved? Are their capabilities, quality of life improved from disease management? So you can see how it all anchors down onto those meaningful outcomes from the patient's voice, hardwired into the system. And that's clearly the cornerstone of value.
In a healthcare system like Macedonia's, where resources may be limited and significant challenges exist, how would you apply the concept of value-based care?
It's a great question. I think I'll probably apply it in three ways. I think the first is, how do we do care delivery transformation? Thinking about populations that are where we can generate the biggest impact. Defining those populations, starting there, and then building care pathways and examining those care pathways. And we can do that today, right? We can look at pilots that look at kind of end-to-end, what does that care delivery kind of look like? And then taking that care kind of infrastructure and thinking, how can we then center that care around the patient? How can we share services? How can we build functions around that then really benefit those patients? And again, this is the second point, is measurement of outcomes, measurement of health outcomes, and enabling the outcomes to be linked to everything that we do in that decision making for that care journey. And then the third component, I would say, is outcomes-based contracting, trying to move towards these beneficial outcomes and linking those to payment is the probably one of the toughest but most important things to work towards.
This is your first time in Macedonia?
Yes.
So you're not well known about the conditions in Macedonian healthcare system, or?
I'm getting familiar with them. I recognize some of the challenges, the high acuity conditions, non-communicable diseases, increasing kind of conditions related to lifestyle factors. There's obviously a high impact on underserved or high needs groups and low income communities, things like that. But one of the biggest things I've learned is the out-of-pocket expenditures are some of the highest in Southeast Europe. And I think this is for inpatient, outpatient care, site of service is very, very kind of impactful in that arena. And so I think even though you say it's a small country, I think the problems are very, very similar to other places as well. And so, I think I've heard that very recently the health minister was talking about 5 different pillars of healthcare transformation. So it's all very encouraging that folks are looking in the right direction to create better value care.
And speaking about the concept of value-based care, can you provide us some more specific example or scenario which could be implemented in Macedonia?
Yeah. So my first-hand experience of value-based care, and the reason why I moved out to the United States, was to be able to be part of setting up a health system based around value and designed around this concept of an integrated practice unit. And so that is, imagine, ideal state of someone with any condition, say a hip arthritis or knee arthritis or shoulder pain, going into a clinic and not only seeing their orthopedic surgeon to talk about the pathophysiology of the condition, behind the condition or the diagnosis or whatnot, but also seeing and experiencing functions from a range of providers in the same facility, seeing a behavioral health trained social worker or a psychologically informed physical therapist, a lifestyle coach, maybe even a financial advisor. And having this kind of whole person approach to care is what I think is at the essence of value-based care. And so my first-hand experience has been involved in setting and developing something like that up and researching it and examining it in terms of outcomes and costs. And much of the work that we've done has shown the benefits of that type of model. If you get it right, you can not only improve the outcomes, but you can also have a lens on costs that can make a very smart, intelligence, data-driven approach to setting up a kind of comprehensive care approach, and then iterating and making it better and better, and pulling in new services and focusing on care transformation that way.
In Macedonia, there is almost a daily discussion about efficiency, sustainability, and accessibility of healthcare. How can your research or practice support if you could give only 3 recommendations to healthcare system, especially those with limited resources like ours, Macedonian, practice in surgery and trauma care? What would you suggest to improve outcome and values?
I think my research is, I would say, in the arena of health services research, and specifically research that's involving health outcome measurement, specifically patient-reported outcomes, both actively and passively. I think they were in the early throes of capturing data passively through wearable sensors and things like that. But before that, I think getting data on capabilities, mental health, social health concerns can help you better understand the impact of these any given health aspect for a condition. And so I'll give you a specific example. So with patients who experienced arm fractures that I studied during my PhD, was able to identify that mental health concerns and aspects such as self-efficacy or resiliency and grit of the patient was a dominant influence on the long-term outcomes of that patient, over and above some of the parameters, the clinical parameters, like even the severity of the fracture, whether it was an open fracture or a severe injury. So that's quite amazing, because in healthcare we're often focused on the clinical and less on the personal factors. And I think the personal factors is where we can pull those levers. And so the research can then allow you to target those personal factors and say, well, maybe I should approach this population of patients not only on my own as the surgeon who can fix a problem, but also hand in hand with a colleague that can help me with behavioral health, mental health concerns, another colleague that can manage social health concerns. We often find lots of examples of, well, the most important thing for me and this patient's recovery was being alone or isolated after their condition, not having social support, instrumental support, not having their mental health concerns tended to. And I think the second area of my research is in the arena of patient-centric decision support. So how can you use these data at the point of care? So this is in the implementation arena. So if I'm at the front lines of care, when I look at this metric, what should I do next for this patient? Is it a simply kind of, well, should we think about surgery, not surgery, but also what type of non-surgical strategies? How can we build care strategies around the patient there? And also, most importantly, share that data with the patients as well. And you know, I think ultimately it comes down to these data then building trust and relationships with the patient. I mean, we do that in healthcare all the time, but thinking about these data like a co-pilot for your care delivery and augmenting your approach. I mean, we don't treat patients without looking at their vitals, their lab tests, their imaging results. Why shouldn't we use the patient voice as part of the conversation, that metric as part of the conversation?
The COVID-19 pandemic put healthcare under extreme stress. In your view, what effects did the crisis have on surgical services, operation outcomes, and care models?
Well, wow. It certainly feels like a long time ago, but it wasn't really, right? And I think that it seemed to have impact at every level. I think at a systems level, I think had significant impacts on workforce distribution. At a clinical level, clearly there were pressures on patients with, especially surgical patients, complications, how you manage these surgical patients in a very, very different way. And I think at a personal level, I think the burnout, fatigue, and all of the kind of the mental health concerns of healthcare professionals and patients kind of came to light when there was such a devastating, impactful global kind of phenomenon. I think technology, I probably finish with the technology layer. I think it triggered innovation through telehealth, of course, but also us to look at things in a different, maybe in a kind of a frugal innovation way. Just thinking, well, how can we maintain coordination, continuity of care remotely with telehealth or otherwise? Do we need multiple appointments as well? I think it triggered innovations in care delivery and processes, and so I think it had impact at multiple levels.
If you could give only 3 recommendations to healthcare system, especially those with limited resources like ours, Macedonian, what would you suggest to improve outcomes and value?
Excellent question. Only 3 things. Wow. I would say lead from the front when it comes to technology. I think clinicians are often, there's a wide variation of clinicians and how quickly they take on the technology. I think with artificial intelligence specifically, I think it's imperative that we are the humans in the loop when we are talking about artificial intelligence-enabled technologies. And so controlling as much of the capabilities of AI through clinician involvement is key. I think, of course, I've mentioned outcomes a lot. There is no value without outcome measurement, and specifically health outcome measurement. And so I think it's leveraging and unlocking the power of patient-reported outcomes. We're still in that realm. And I mean that at an individual level, so working on the front lines with these data, but also at a systems level and thinking, how can I use these data to make decisions about my care delivery, my resourcing, my utilization. And finally, I think care transformation around value doesn't have to be complicated. I think we have, as we always do in healthcare, kind of oftentimes over-engineer like the system. And I think that simple starts, moving from 0 to 1, care pathway mapping, understanding that end-to-end flow of care delivery, and then where are the levers for improving outcomes, but also efficiencies, which is mentioned a lot in North Macedonia, can work. And it sounds like that's what's happening already in the country.
Dr. Јајакумар, thank you for this interview and sharing with us your knowledge and views.
Thank you very much.
Ете, почитувани, доктор Јајакумар ни покажа дека иновациите во здравството не се секогаш технологија. Понекогаш тоа е нов начин на размислување, каде најважен е исходот за пациентот. Неговото искуство не подсетува дека и со ограничени средства можеме да создадеме систем кој нуди повеќе вредност и подобра грижа. Ви благодариме што сте со нас, останете на фреквенцијата на Телма и имајте убав ден.